Okay, this is video part 2, ECG overview. So we talked about the perspectives that we can see with the leads, and now we're going to look a little bit deeper dive, and this is for your information, and to remind you that we are in the extracellular recording perspective when we're looking at ECGs, and that means that we will see on the body surface smaller amplitude changes in voltage because the currents are going to be smaller than if we're looking about in the intracellular recording perspective with one electrode on the inside of the cell and measuring the difference in charge between that place and on the outside of the cell. So 110 amplitude in terms of millivolts, an action potential, and then the action potential wave of many cells, like the P wave, atrial cells, would be much smaller, and it really depends on which lead you're looking at and also the person that you're looking at, whether they have a lot of tissue in between the electrodes, so a very thick chest, or a very thin chest without much. The tissue provides resistance to current flow and makes the voltage difference that we are able to see on the surface much smaller. So I just want to give you a little idea of how this measurement works. So we have a potential measuring or voltage measuring device, and we're having a model cell here shown here, and we're looking at the perspective that that bipolar lead, for example, would show. And in A, we're looking at depolarization approaching B. So A is measuring the extracellular charge difference between the location of A, and B is measuring the charge that is at B when that region has not yet depolarized. And we are reading B minus A, and so in position in the cell at time A, we see B minus negative A is going to equal a positive deflection read by these electrodes. Now I want to step you over to A1, and A1, the electrodes now are measuring that kind of wave that returns to isopotential. And the reason that it does this is because the electrodes now, there's still a difference between A and B, so B minus A, but now the positive amount of B is getting smaller, okay? So that that it's approaching zero. And then when the cell is completely depolarized, and there's no difference, and we could also think of the heart, all the ventricles are completely depolarized, there's no difference between A and B, we are at an isopotential because there's no charge difference between those two locations. And this is like during the ST interval, okay? And now we are going to look at the Y trace would go in the downward deflection, and this is repolarization, for example. There are other situations in which this could occur, but this is repolarization, and it's in with the same vector. So A now becomes positive, and B is negative. So we're subtracting B minus a positive A and getting a downward negative deflection. And then I've drawn C1, and C1 shows that we're having repolarization, but so we're still in the downward direction, but the difference between A and B is getting smaller. And so we're approaching zero. And then finally, the heart is back to resting potential everywhere, and we're back in an isopotential time because there's no difference in charge between A and B. Happy to chat more about this in person. Okay, this is from your textbook, and it shows the same thing over in D, and just showing you how when the depolarization is approaching that positive electrode, the trace goes in the upward direction, and all that I've covered in the previous slide. Now I want to show you a little bit about how this using comparison between different leads can give you information that is clinically relevant. And this is just a taste. You'll learn more about it in other classes. So this is our normal trajectory or vector of a major current flow during the R wave that gives you an upward and downward deflection like we just talked about in the previous slide. And that's as expected. Now in B, the R wave is smaller than what's seen in lead 3 because now the vector, the major vector of current flow has shifted so that now lead 3 shows a larger amplitude R wave. And this could be, for example, if the right heart, the right ventricle has hypertrophied. So this would be one example of a way that the ECG can give you information about the state of the heart electrically, in addition to the things that we already know and that are maybe a little bit more straightforward. Okay, so this is looking at left ventricle hypertrophy, and now the major current flow is in a vector that is more along the axis of lead 1. And so lead 1 now is showing the largest R wave. And this is if the left ventricle had gotten bigger, and so more cells were firing action potential synchronously. Remember, the amplitude of the waves is proportional to the number of cells that are electrically active. And I'm going to let you look at this in this handout, and I'm not really going to go through it. I think it's useful in some ways, but not useful in other ways. So I'll just say that our explanation above is good, and that's the most relevant. The only thing to note is in D, instead of having this is showing that the electrical current is flowing through these two cells in this direction that's parallel, but now the electrodes are placed perpendicular. And so they are seeing the same charge distribution when the current passes through. And so if we had B minus A in this situation, since B equals A, we would see 0. So the electrode placement is important for being able to read information about the electrical activity. The next slide is also from your slides, and it's trying to show you the key directions, vectors of current flow. And I think we already talked about it, so I'm just going to say, look through. We have atrial depolarization for the P wave. We have septal depolarization for the S wave. Oh, excuse me, for the Q wave. So here, let me do P, Q, R, S, T. And so septal depolarization goes from the left to the right side as its major vector. And so that looks like a downward deflection. And then left ventricle depolarization is that major R wave. And we've talked about why it looks that way. And then the S wave, again, the major vector is going towards the base. and that's why it's downward deflection away from the lead 2 electrode that's we're looking at. And we are now in this isopotential ST segment, and that's when there's no change. The major ventricular cells are all depolarized, so there's no difference between that B electrode equals the A in terms of charge, and therefore B minus A is equal to 0. So we're in the isopotential phase. And then we have repolarization from the base to the apex, and that looks like an upward deflection in the T wave. So this next slide is from your textbook, and it's just, again, reviewing kind of the major components of the ECG. So the PR segment is isopotential because the cells whose activity we can read on the surface of the body are the atrial cells and the ventricular cells. And the atrial cells are depolarized at this time, all of them. And then the ST segment is when the ventricular cells are all in that same state of plateau phase depolarization. I'm just going to draw the action potential of one cell from an intracellular recording that we would expect, and the same thing goes for a ventricular cell that we would expect to see during that time. So this is from boron. It's a little bit more detailed of a slide, and again, the events, the electrical events that are occurring are SA node excitation that leads to excitation of all the atrial cells, then AV node excitation that leads to then conduction through the bundle of hints, bundle branches, Purkinje network. We cannot see this electrically because there are just too few cells firing action potentials, but that the timing of that PR interval in the PR segment, this region, give us a lot of information about the conduction velocity. So it's a really important part of the ECG. And then we already looked at the Q, R, and S. And then again, just to let you know and remind you that that ST segment is the time of the action potential plateau in the ventricular cells. And a change in the ST segment gives you a read about that change in that, the number of cells, or sorry, the duration of the plateau. ST segment amplitude variation, so if there's a shift in the upward or downward direction, often accompanies myocardial infarction, and so that can be super important and significant. And then also timing, so if this ST segment gets longer or shorter, getting shorter is typical when your heart rate increases, and getting too long can lead to increased ventricular excitability, and we'll talk about that more. So here are some times that are kind of the standard times of a healthy person. So 120 to 200 milliseconds for the PR interval, QR, S 80 to 120 milliseconds, and then the QT interval 350 to 430 seconds. Okay? And then we talked briefly about how we use this data to calculate heart rate, and I wanted to let you know there's standards so that if you're measuring, if you have a heart issue and you're in China or you're in Peru or you're in Africa or you're in New York City, you can kind of expect that the conditions for measuring the ECG are kind of standard. And they're usually taken at 25 millimeters per second, and that means that each millimeter box, these little tiny boxes, are 40 milliseconds, and that means that 40 times 5, 40 milliseconds times 5, because they're 5 little boxes, is equal to 200 milliseconds. And I think I call the square, this is a square, and these are little boxes, but I may have done it in the opposite way, so we'll have to check as we go. But okay, so I'll be clear if it's on exam. So if we're calculating the heart rate when the rhythm is regular, you can count the number of milliseconds between a beat. And so I've done that. And so I counted, and I saw that there was one beat in 800 milliseconds, and then I just need to get to beats per minute. So there are 100 milliseconds per second and 60 seconds per minute, and that leaves me with 75 beats per minute. There are a couple of other ways to measure heart rate or calculate heart rate from the ECG record. And with this standard chart speed, there are 300 large squares. So that's a large square in a minute. And if the rhythm is regular, you can count the number of large squares between 2 QRS complexes, and I'll show you how I did that, and then divide into 300. So 300 squares per 1 minute. And in this case, there are 1, 2, 3, 4 squares per 1 beat, and I can easily see that's 75 beats per minute. So this is a textbook picture, and it's just kind of showing you in general, that general perspective view of the depolarization in purple and what we record on the surface. But we've talked about that kind of in more detail in the previous slides. So I'll let you read the text in your book, and then if you have questions, check with me. Here is another example that was in your slides, and this really walks you through kind of how you would approach interpreting an ECG from a patient that had a problem for which you are running an ECG. So when would you run an ECG? If somebody came in with chest pain, if they were faint or had a fainting episode, if they felt dizzy regularly, or they were noticing irregular beats, or you noticed irregular beats when you were doing a cardiac exam. So the first thing you're going to do is calculate the heart rate and note using the procedures that I showed you above. And you're going to note whether the rate is normal. So normal is considered between 60 to 100 beats per minute. If you have a heart rate greater than 100 beats per minute, then you're considered tachy, too fast cardia. And if it's slower than 60 beats per minute, it's considered bradycardia. And then the next thing after that, the rhythm, you're going to look at, is the rhythm regular? So are the beats regularly spaced? We'll talk more about heart rate variability and some other challenges. That heart rate variability is a good thing, but we'll look at some challenges that may show you irregular rhythms. And then are the normal waves present, and are they in a recognizable form? So is the P wave going in an upward direction? And then is there one QRS for every P wave? And if yes, is the PR segment constant in length? Okay, so we've talked about, thinking about the segments, and we've talked about the intervals and how that timing can give us information. So how can you apply this? So I have 2 different ECG traces, and my questions to you are the heart rates, what are the heart rates? Are they normal, or are they a little faster than normal or slower than normal? Is the rhythm regular? And are all waves present? Are the segments constant in length? And I think just from looking at the waves, you can say for both trace A and trace B, the rhythm is regular, all the waves are present, and the segments are constant in length for the patient A and then also for patient B. So I just want to show you that I have the heart rate calculation done in both ways. So we're looking at 1 beat per 520 milliseconds for A, and then this person's heart rate is 115 beats per minute. And if you use the box method, 10 beats per 26 boxes, in each box is 200 milliseconds, and we go through our dimensional analysis and we get the same result. So this patient has tachycardia. And then if we look in the at patient B, we have 1 beat per 1600 milliseconds. We do our dimensional analysis, 1,000 milliseconds per second and 60 seconds per minute gives us 37 beats per minute. Okay, if we round up 38. And then if we do the beats per box, we have, looking at the longer trace averaging, 3 beats per 26 boxes, and 1 box is equal to 200 milliseconds, 100 milliseconds per second, 60 seconds per minute, and we're getting 35 beats per minute. So the slight difference between the B, and so we could, I would stretch it, I would say it's within that regular rhythm, but you might say, wait a minute, Dr. Davis, we need to sample more, so we could see if they're, if when we average, we find out that there is slight differences. So the last is a set of challenges from your textbook. And here I have that, why would you do an ECG or run one? You know, you don't get that with your regular yearly exam, but it's usually when somebody comes in with some of these symptoms that could indicate a cardiovascular problem. Chest pain, dizziness, fainting, irregular rhythm, and also sometimes for chronic high blood pressure. So we are reminded that we need to check the rate, is it within that normal range? Then we're going to check the rhythm to see if it's regular. So if we sample, and this sampling is for 10 seconds, is it regular within that range, that time frame? Are all the normal waves present in a recognizable form? And they are for A, but I would say for number 4, they are not. For number 2, not all the waves are present. And number 3, they're not all present, and same for number 5. Okay, so if they're not all present, then that tells you there's something up. And then, is there one QRS complex for each P wave? That is not true for number 2. Okay, and then there's some other questions. So that's all for now, and we'll talk more about this in class.